turn it over to Sarah.
Thank you so much, Tiffany. Hi, everybody. I will share my screen here. Let's see. Okay. We should be up and running. All good?
All good, Sarah.
Okay, good. Ooh, let me just do this. Okay, so we'll dive in. I'm grateful to be with you today, and Tiffany, thank you for the introduction. As Tiffany mentioned, I'm an assistant professor here at the Virginia Health Sciences at ODU, formerly EVMS. We've gone through an integration, which is why the name looks a little bit different. Same research, same efforts going on here, but a new name. I also have the pleasure of being the assistant director of the Consortium for Infant and Child Health, which really allows us to link the research and the work that we're doing here, sort of on the academic side, into the community and with the community. So a lot of my work, as you'll see, is focused on really authentically engaging the community, working alongside the community to blend research and practice together and to sort of meet our collective goals. So today I want to talk a little bit about breastfeeding equity, sort of bringing you into my space, focusing a lot on infant feeding, on the first food, and focusing on breastfeeding. And I'll use that term as we go through the presentation, breastfeeding as opposed to chest feeding or human milk feeding or pumping. So just to be aware that I'm using breastfeeding sort of interchangeably and not meaning to exclude anyone by using that phrase. So the goals of this presentation, this discussion, is to understand the current breastfeeding data and trends. We'll go through a little bit of a snapshot in Virginia, talk a bit about ongoing and future research here locally that I've been involved in Hampton Roads and that we're collaborating on through my work. Also exploring some of the equity issues that you may or may not be aware of. They are very similar and parallel to the equity concerns that I'm sure you see in overall birth and maternal health outcomes. And then highlighting some local efforts here in Hampton Roads. So I'm based in Norfolk, and the Hampton Roads region sort of encompasses out through Virginia Beach and up the peninsula. I know you all are throughout the state. So just to give you a little bit of a picture of where I am here, and then talk about some strategies to potentially increase breastfeeding equity based on what the research has been saying and based on what we're seeing in our community. So a little bit of data here. We won't go too far into data, but I thought important to just set the stage with this discussion. So a Virginia data snapshot, 87.4% of mothers report ever breastfeeding or pumping. So this means then when they were asked, have you ever tried to breastfeed or pump? If they answer yes, they get looped into these numbers. And this is from the Centers for Disease Control. It's the Pregnancy Risk Assessment Monitoring System, or PRAMS. PRAMS is a really robust and reliable database for a lot of birth and breastfeeding outcomes. So this is where I like to pull a lot of the statistics that I use, just keeping a consistent platform where we pull data from, knowing that there's some variance in the data from different platforms, and there's obviously pros and cons of different data collection methods. But just keeping consistency here. So then you'll see as we go down the chain, 75-ish% report still breastfeeding at 1 month, and then we drop all the way down to almost 45% still breastfeeding at 2 months. So just seeing here the way the trend goes down as we increase in time is an important thing to note as we think about breastfeeding longevity, and just to consider why some of these people are starting to breastfeed and then stopping. We'll talk a little bit about the barriers and the challenges that they may be encountering and how we can sort of work to disrupt that. So how do we stack up according to the national average? We're often looking at comparisons. Where does Virginia stand? Where do we stand compared to other states and compared to national? So national, we're at about 84% ever breastfed. And the Healthy People 2030 target is 84.1% of, again, that breastfeeding initiation. So yes, I have ever tried to breastfeed or pump. So at first glance, it looks like we're doing pretty well. Virginia is stacking up pretty well nationally. Our breastfeeding initiation rates are fairly high. I'd like to paint a little bit more of a picture to this. There is more to the story here. So when we dig a little bit deeper into the data and we look at it across different subsets of the population. So in table 1 here, I've sort of grayed out the other lines. They're looking at specific health districts. We have Richmond and Blue Ridge. So these districts might be of interest to you, but this green line is across all districts. And so what you're seeing is the breastfeeding initiation rates. Again, that's that ever breastfed number. And you can see that it's actually been slightly decreasing from 2017 all the way down through 2021. This is the most recent data that we have from this data set right now. You see big dips in 2020 across all of the health districts as well as the aggregate. And that really is, there's been a lot of assumptions and discussions on what that could be. Obviously, 2020 is the year of COVID. 2020 was an election year. There was some change in the political climate, some change in policy. We could have more discussion around what that dip might be attributed to, but I think the important thing is to acknowledge that there has been a dip and that even now or in 2021, sort of post, we're climbing slightly, but not back to our pre-2020 rates. So when we have more data, we'll be able to see where we are 2022, 3, 4. Have we climbed back up? Are we back to that sort of 2017 number, back at a more even trend? But I think the important thing to note here in table 1 is that breastfeeding is influenced by external factors. So it's not steady across years, it's not steady across geography and populations. It is influenced by things like a global pandemic, policy changes, changes in political leadership. So all of these things have an impact on breastfeeding and ultimately on the health of our communities. Looking over here to table 2, and I should mention as I go, we'll have time for questions at the end, but please, if you have something burning or a point of clarification, a discussion item that you'd like to bring up, feel free to raise a hand or to just chime in and interrupt me. Otherwise, I'll keep sort of blowing through it and we'll discuss at the end. So over here in table 2, you'll see the gray line represents that initiation rate. So if you were to take the green line from table 1 and pull it over into table 2, that's what you're looking at. So again, those pretty high initiation rates on first glance. 89% in 2017, and we're at 87.5% in 2020. We're doing pretty well getting people to try ever breastfeeding. But sort of the bigger story is when you start to look at this blue line. So the blue line below, that represents breastfeeding at the time of the survey. So when the PRAM survey goes out, it's given to mothers normally 2 to 4 months after giving birth. So we're looking at 8 to 12 weeks sort of in that time frame, and seeing if they're still breastfeeding. And we're seeing significant dips in that. So only about 69% in 2029, 2 to 4 months after birth, we're still breastfeeding. So this mirrors the earlier data that we're seeing in terms of the steady declines. People may try it once or for a short period of time, but we're really seeing drop-offs. So I think the important thing to note here is that breastfeeding initiation data, that ever breastfed number, is not necessarily a reliable measure of how well our community is doing when it comes to breastfeeding. We really need to dig a little bit deeper and look at the longevity of breastfeeding in order to figure out where and how to intervene. Because at first glance, we could say, oh, we're doing great, 87.5% ever breastfed, thumbs up for us, we're doing a great job. My argument is that there's more depth to this story. And even more than that, we see when we start to break up the data by race and ethnicity, by education, and by income, we really start to see the differences across subsets of the population here. So the first table, table 3, is showing you breastfeeding initiation by race and ethnicity. And we're seeing that those who identify as non-Hispanic Black are at an 82% initiation rate, compared to those who identified as Hispanic in the survey are at 97%. So that's a 15% swing just within those race and ethnicity groups, that we're seeing disparities in breastfeeding rates. And it's important to note those, again, as we think about how to work with our communities and how to conduct research and create interventions for our communities. You see the same thing with level of education and income level, that it's inversely related to breastfeeding success. So the higher your level of education, the more likely you are to have initiated breastfeeding, and ditto with income. The higher your income level, the more likely you are to have initiated breastfeeding. So again, just important to have an awareness of those things and recognize that breastfeeding is not created equal across geography, race, ethnicity, education, income. These are all important factors that are external and are influencing a person's decision whether or not to breastfeed. We know that most people decide during pregnancy whether or not they're going to breastfeed, and we know that there's a lot of factors that influence that. There is healthcare influence, social support or lack thereof, their own personal previous experience with breastfeeding, as well as their family and close kin experience with breastfeeding, those cultural and historical practices that can be really deeply rooted. And we'll talk a little bit more about this and what might be impacting that decision to breastfeed, that initiation rate. But again, we see that initiation might not be a great indicator of breastfeeding success, but it can be an indicator of what is going right or wrong, sort of at that prenatal point, in hospitals, in messaging campaigns for pregnant women. Those can play a role in this decision whether or not to breastfeed and how it's impacting certain subsets of the population. So moving forward here, digging even a little bit deeper into the different counties in Virginia. So we talked about a lot of the differences across race, ethnicity, education, income, but now thinking about geography. And as you'll see here, the dark green areas are where we're seeing less cessation in breastfeeding. So this reflects people who stopped breastfeeding before 2 months. So people who started, we clocked them in that initiation rate, great, but then by 2 months they had stopped. And as you can see, we have counties sort of up in the north here, it's like Fairfax and Loudoun, that are doing really well. They have between that 0 to 25% of their people who are surveyed that have started breastfeeding are stopping before 8 weeks, so that's pretty small. And then you see in some of our areas down here, the more dark purple color, in the south part of the state and moving into the west, you have 36% or more of people who are stopping breastfeeding before 8 weeks, 8 weeks after delivery. So again, just locating sort of your own county, getting an understanding of what these rates look like for you. And so we're here in Hampton Roads. I don't know if you can see my mouse, but we're here in the Hampton Roads area in the southeast corner of the state. And even within Hampton Roads, we think of it as one big region, but there are several different counties here that are performing better than others in terms of breastfeeding. And so just to think about the specific needs of those communities. So Insert 757 Breastfeeds, a coalition and initiative that is near and dear to my heart. We started this coalition about 4 years ago. We have been working across Hampton Roads to promote human milk feeding. Really, the idea here is that we build a supportive community, that we think about what could human milk feeding look like in a sort of perfect ideal world. So we work with our hospital systems to really understand their policies and practices around breastfeeding and see where we may be able to work together to improve or intervene. We provide trainings to community members as well as professionals. We've done trainings with home visitors, with nursing staff, maternal and child health professionals across the board. So we meet quarterly as a group as 757 Breastfeeds, and I think I see a few familiar faces on this call. But really the mission is to build this community, to build this network of professionals, of people who are passionate about human milk feeding, and of people in the community. So I wanted to just use this slide to share a few pictures. If you're so inclined, there's a QR code to our Instagram, which we try to keep really live and active and post updates about upcoming events and informational tidbits and really get some good engagement with the community. But there's just some of our moms at one of our breastfeeding events that are enjoying it with their little ones, sharing supplies and information with our hospital partners and folks in the NICU. So just wanted to share sort of the faces behind the initiative. Sometimes we, and I'm included in that, we as a researcher get really caught in the data and the numbers, but important to sort of come up for air and remind ourselves of the people that are in our communities that we are working collectively with to solve this issue. So a lot of what we do in 757 Breastfeeds is working collaboratively. So finding our partners on the ground, working with WIC, with social services, with the Virginia Department of Health, with our partner coalitions. There's a really wonderful breastfeeding coalition in Richmond, RVA Breastfeeds. They're doing wonderful and very similar work, again, to look at these societal barriers, to start addressing challenges to breastfeeding equity, to implement policies that support that, provide trainings and education to the community, and to ultimately create a more breastfeeding friendly community and really build those social norms back in. Every year we host a breastfeeding bash in August during National Breastfeeding Month. And so we're just off the heels of that. We hosted it on the 10th, just a couple of weeks ago. So we're still excited and invigorated from that event. And during that, we bring a number of community members together. This year, same as last year, we had just under 300 community members, families come out to the event, and we really tried to create it as a sort of health fair meets carnival meets backyard barbecue. We have food trucks and snow cones and a bounce house and carnival games. And we also have 50 partner organizations that come with their tabling gear. So that's sort of the health fair part. We have doulas and midwives, lactation consultants, WIC, social service providers, academics conducting research, all sorts of different sects of this population. And that way, when families come to the event, they're able to make their way through all of these tables. They're interacting with partners, with lactation consultants who they may not have the opportunity to access. So really trying to build access, put everyone physically all under one tent, all in one place, and allow them to come with their families, their partners, their friends, and have a really enjoyable and celebratory morning while they're receiving a lot of really valuable information. So we found that we're helping people to connect to the resources that they need by bringing them to an event like this. And importantly, again, putting my research hat back on, 757 Breastfeeds is diving into quite a bit of research, really to understand the impacts of breastfeeding and the experience of breastfeeding for our family members here in Hampton Roads. So I think and talk a lot about going beyond the numbers. So beyond this idea of 84% breastfeeding initiation and really looking more into the stories of the people. Who are those 84%? So I, in collaboration with my colleague, Dr. Hoagland, we worked together on a qualitative study, Human Milk Feeding in Hampton Roads. And so through this study, we interviewed a body of students, interviewed 60 people in Hampton Roads. The conditions for being included in the study were that they had to have been pregnant or delivered between January 2020 and December 2022, and they had to have attempted breastfeeding at any point postpartum. So again, that's that I tried once, very sort of low bar, just having to have attempted breastfeeding or pumping or expressing in some way. In the study, we had a really good mix of racial and ethnic groups as well as geographic diversity. So we had percentages that echoed the percent in our population. So we felt pretty good about the mix there. And in doing the analysis, Dr. Hoagland pulled out some key themes. And what we were hearing from folks were a couple of these main points here. And again, these are interviews of 60 people in Hampton Roads. It's not the full story, but it is a deeper story than just looking at the percentages. So the themes that we heard over and over again were that postpartum care does not focus enough on breastfeeding or pumping success, that there had been a lot of information shared with them around mental health and excuse me, and caring for baby after pregnancy, and thinking about feeding, but not necessarily thinking about breastfeeding. They didn't feel like they were well supported either with their healthcare provider or with their support at home. They didn't feel like they had enough support to sustain them in that postpartum period. So that's valuable information for us. Then, as we can assume, many of them said that returning to work created significant challenges. That's why we see those data dips, particularly at 3 months when we go from initiated to 3 months to 6 months. At 3 months, when a lot of folks have gone back to work, you see big dips in breastfeeding rates. And so that's, from me, from a policy perspective, that's a place where we can work with workplaces to make sure that they are breastfeeding friendly, that they are practicing best practices in creating breastfeeding friendly spaces, and that they're allowing their employees time and space to pump, that they're following the laws required of them, and that moms are knowing how to advocate for themselves with their employers or knowing how to connect with people like us, and I'm sure many of you on the call, who can connect them to the appropriate resources. So again, points of intervention here. A couple of the other themes we noticed, they wanted more recognition that breastfeeding is hard. They wanted recognition from their healthcare providers, from their social circles, their families, that this was a really challenging thing for them, and that it was okay that it was challenging, and that they were going to be there to support them. I think a lot of what they reported hearing from healthcare providers was, if this seems hard, and so we'll just move to formula, or we're having some concerns, so we're going to move to formula, and not necessarily having the discussion with that parent about, is this moving to formula indefinitely? Can we supplement? Can we get back to breastfeeding? Certainly we want babies to be thriving and gaining, but just thinking about continually integrating breastfeeding into that space. And then our last themes here, lactation classes and educational resources are not necessarily reaching into the community as we want them to be. So in public health, we really want to be having big, broad impact. We want to be reaching, deeply into the communities who need it, specifically where we're seeing those inequities and disparities in breastfeeding rates. And what we're hearing from our community here in Hampton Roads is that we're not really reaching them. Just plainly. And where they are finding their information is on Google and on social media. So again, an opportunity for us to change the way that we interact. And maybe it's less education classes and more social media virtual education classes. Maybe it's more things where they can come together for that social support and get that understanding that breastfeeding is challenging, and also provide lactation support. So a lot of creative ways to think about what this could mean in practice, but important just to understand the themes of what the people behind the numbers are saying. One more study to discuss here. So I worked with a medical student over the summer. We have been, I'll dive a little bit deeper into the bigger picture of this work, but she was working on looking at the effects of contemporary and historical experiences on Black breastfeeding in particular. So she did a literature review as well as some listening sessions. And in her lit review, she uncovered these major themes, which you'll see listed as really having a mitigating effect on breastfeeding initiation and duration. So we're seeing these decreased rates in people who are identifying as non-Hispanic Black. And so really wanting to understand where does that start and end, and what are the influencing factors? And while it's a very complex web, we wanted to see what does the literature say, and then we wanted to hear what do the people say. So the literature is saying the effects of slavery are really significant on the decision to breastfeed, even still. These cultural and historical and familial practices of breastfeeding or of not breastfeeding are pervasive in a person's decision to breastfeed currently. We're also seeing that this internalized perception of a body and what it means to breastfeed is influencing someone's decision to breastfeed. So oftentimes it's what they hear externally and societally and then internalize. So thinking about the impacts of that on breastfeeding initiation and duration. And then employment challenges, as we heard in the focus groups, that it was difficult to go back to work. It limited their employment opportunities, employment locations, and that they had to choose breastfeeding or my job. And that's not a choice that anyone should have to make. The other things we heard were immigration status, that this was really affecting decision to breastfeed, particularly if people had family that were coming from outside of the US, that those practices were different than people that are born in the US, so foreign born versus born here, and that had a major impact, again, speaking to that sort of cultural and historical generational impact. And another important one I'll point out here is breastfeeding education. So the quality and presence of breastfeeding education, the access to those services had a major effect on their decision to breastfeed and their continued ability to breastfeed. So I said we looked at the literature, but then we also wanted to make sure to hear from the people. So we hosted several listening sessions via lunch and learns, and these sessions mostly had professionals who work in maternal and child health, who work in lactation, and there were several community members at these sessions as well. And when I say community members, I mean folks that don't necessarily identify with an organization. While a lactation consultant may also be a breastfeeding mom herself, she sort of identifies with an organization. So I think of it all as community. But in these listening sessions, we saw a few major themes, and they echo what you've seen throughout already. So a major one, racial bias and stigma in healthcare. So healthcare providers assuming that the patient would be either breastfeeding or using formula based on their race. So making some of those early assumptions and impressions without asking, or asking differently based on the person that you're seeing in the room, making assumptions on income and education and what they intend to do going forward. So an important thing, we value and honor our healthcare professionals so much, and I think just important to bring this awareness at a little bit higher level to our professionals, that patients are being impacted by some of these maybe unconscious assumptions. Another theme we noticed is, again, repetitive employment issues. So employers not providing adequate time and space for pumping. We know there are laws that protect breastfeeding parents in these instances, and I think it's just connecting them to supports and services that can help them advocate for themselves in these spaces, and working with employers so that people don't have to advocate for themselves. So employers are doing what they need to do to provide a supportive space from the beginning. Partner and spouse support while breastfeeding. We talked about the family unit, and that being a really important, crucial piece on someone's breastfeeding journey. So some were worried about what their partner would think, worried that their partner wouldn't bond with the baby if they were breastfeeding, or their partner was worried and they were putting those concerns on them. So we see it with those sort of interfamilial pressures, as well as external societal pressures. So healthcare providers presenting formula after the patient said that they were breastfeeding, and sort of, while it was likely well intended by the professional, or maybe there were medical reasons for it, the interpretation by the patient was that they couldn't be trusted to breastfeed, or that they were going to fail breastfeeding. And so it sort of put this undue pressure on them, and concern that they maybe weren't going to be good enough or successful at this, particularly for a first-time breastfeeding person or someone who is the first in their family to breastfeed, or maybe the first for several generations. This little bit of doubt really impacts a person's decision. Okay, so this all ties into an offshoot of 757 Breastfeeds. And this sub-initiative is called Reclaiming Lactation. And I wanted to share the team. While I'm here talking today, I am not by far the only one or even the lead one working on a lot of these efforts. As you'll see, the research I've done is collaborative with others. And this core team, Reclaiming Lactation, these are the friendly faces and the people who are leading this effort. So I want to honor and recognize them, Tiara Langley, Andrea Ward, Nichelle Clark, and Jasmine Cottrell. They are the core team that has started this effort, recognizing that we are seeing lower rates of breastfeeding in the Black community, knowing that there's a complexity to the rationale behind that. And so really wanting to, again, dive into the stories of the people that we are working with and hoping to serve. And so this is what we've created. We have our newly minted logo and a little bit about what we do. So we are promoting the voices and stories of Black breastfeeding people. We know what the data says. We are steeped in the data. We know what the Lit Review says. Now we want to hear the voices of those who are doing it in our community. So in order to do that, we've put together this diverse group of people, and we meet and have lunch and learns, and we have our leadership meetings, and we discuss Black breastfeeding. We discuss what it looks like in our community. We offer trainings, we offer CE credits for these trainings when we are able to. And really the idea is to just build capacity in our community for everyone to have an understanding of what this research could look like and what we want to get out of this and how we want to share these stories outwardly. So by creating this inclusive team, we're really hoping to add to the body of literature, of research around Black breastfeeding, and to have it be deeper than the numbers, to really highlight the stories. And through doing this, we continue to connect with our community organizations and families. So we've spent the last year really building relationship and building trust in the community, again, through having these lunch and learns, through having sort of side conversations, coffee chats with stakeholders, professionals, community members, so that when we come to the table and move into the research, we're not seeing these folks for the first time. They're not seeing us for the first time. We're familiar faces. They feel comfortable to an extent with us. They feel safe with us. So that in the fall, we intend to dive into focus groups and key Informa interviews, again, elevating the voices and the stories. But we don't want it to be the first time that they're seeing or hearing from us or hearing about what we're trying to do here. So that's the mission of Reclaiming Lactation. We're really excited about it. It's funded by the Jeffress Trust Foundation, so we're grateful to them for the support of this important work. And just in wrapping up here, I wanted to talk about some tangible-ish strategies that we all can use, I think, to increase breastfeeding equity in your communities, in your respective work. So one of the big lessons that I've learned over my time here is to engage your community, to really rely on your community, to work with and alongside the community. I think rather than seeing it as them, the community, and us, the professionals, it has to be this blended idea of we're all working together towards the same goals or similar goals, or let's figure out what those goals are and let's find common ground, and let's bring our collective resources together. I have a public health background and a research background, and I bring that to the table. But what I don't bring to the table is the experience of someone who is trying to breastfeed and going back to work and has a toddler running around, sort of that family experience, that lived experience that someone else will bring to the table. So I think to see that all as equally as valuable and know that we need to come together to solve these issues, and it should be with our community rather than just for our community. A couple other really important pieces of this: healthcare provider training, particularly around decreasing biases and building cultural humility. So that recognition of maybe the subconscious decisions that providers or professionals are making when they see a patient. And then working to support your community-based initiatives, so breastfeeding coalitions that are across the state, home visiting programs, peer-to-peer programs. Oh, I'm so sorry, it should say peer counselors. Apologize for the typo. And other support groups. So really supporting those people who are on the ground, working in the community, building trust and relationships with the community, and not reinventing that wheel, but tying in and uplifting what they're doing instead. And then big picture here, working to advocate for policies and address structural barriers and biases. So making sure that workplace policies are really holding strong and being implemented in your local workplaces. Looking at your internal policies, if you're in a hospital or a healthcare clinic, what are our internal policies around breastfeeding and how are they being implemented in real life? Do we need to make changes here to be more supportive? So there are small p policy and big P policy things, from addressing your own internal workplace policies and rules to advocating for policies at the state and federal level. There's a whole gamut of areas where you can be involved in advocacy and policy and systems change. And then collaborate. This one should be, I think, in big letters, along with engage your community, really remembering that your partners at the table, your professional stakeholders, your people living in the community, your universities, your hospitals, all of those partners are really essential in doing this work. And sometimes it's the partners you wouldn't think of. It's a bank or a baseball stadium. And they are bringing something to the table. They're bringing funding, or they're bringing business expertise, or they're bringing a venue. So thinking about those non, sort of normal partners, not the ones you would normally go to, and thinking about getting them included in the work and really building teams and relationships that you can go back to. So not just collaborating for, I need this today, but thinking about building a relationship so that when you need something tomorrow, you have that strong relationship and you can just call or email that person and say, hey, listen, we would love your support. And they say, sure, Sarah, happy to be involved, right? So really building those connections in your community to get the work done. So I hope this has been a useful and productive time for you. Thank you again for allowing me the time to talk through some of the research that we're doing here and some of the equity issues that we're seeing in breastfeeding. And I am happy to entertain questions and have discussion, happy to have anything you'd like to share. Thank you so much.
Thank you, Sarah. That was a great presentation. Thank you for sharing it with us today. There is one question in the Q&A that I will share. If you have any other questions, please feel free. You can put them in the Q&A, or you can put them in the chat, or you can probably even just unmute if you'd like to speak it rather than type it. But I'll read the one that we have here. It says, I recently worked with a pregnant inmate on Suboxone, and she wanted to pump and have a family member pick up milk and bring to the neonatal unit for her baby. The jail refused the request, stating they didn't have proper storage for breast milk. We have a plan to meet with the jail to discuss a plan for the future. Are you aware of any resources that could help implement a plan for the jail to allow inmates to pump and store milk?
Mm-hmm. Yeah, a great question, and something that we hear often, breastfeeding concerns for people who are incarcerated or who are in jail. A colleague of mine is actually starting a study looking at thousands of people who are incarcerated, and I believe that she may have some resources as well for setting policy within those systems. So let me reach out to her. And can you share, Tiffany, who is the person? I don't think I can see the Q&A, and I'm happy to send this information to them.
Oh, yes, it was Heather May.
Okay. Heather, if you want to send me a note, I'll put my email again in the chat, and I'm happy to get back in touch with you.
Okay, thank you so much.
Thank you.
Any other questions?
I just was gonna say I see Heather's note about Milkapalooza in Lynchburg, and yes, it sounds very similar to the breastfeeding bash, and I've seen videos and promo for it. It looks amazing. I think that's the work that we all, should be excited about doing.
All right. If there aren't any other questions, I'll just remind everyone that we do record and post the webinars. Give us a few days and it should be up by next week. And then you can review it or share it if you like. And then look out for our next upcoming webinars. You can find them on our website, govnpc.org. And thank you everyone again for joining today. Sarah, you can hang back for just a minute, and we'll see you all next time.
Thanks, everyone.